Hi there, my name is Alex Miller. I'll be going over the Yamane technique, and I had to do a repositioning at the end here. So to start off, I'm making a paracentesis on the nasal and temporal aspects of the eye, and I'm doing that with a 15-degree blade. I then like to inflate the anterior chamber with viscoelastic, and then I make a 3.2 millimeter biplanar corneal incision. After that, I like to take the toric IOL marker to mark the 3 and 9 o'clock positions for IOL placement. I then like to confirm with the cyclodialysis spatula. Moving on, I like to use a caliper. I set that to 2.5 millimeters. I then measure that to about 2.5 millimeters posterior to the limbus at the 3 and 9 o'clock positions. I then measure 2.5 millimeters superior on the left-hand side and inferior on the right-hand side, and that kind of marks the scleral tunnel that I make with the TSK needle. I then take the TSK needle and bend it at about 90 degrees, just like that. And then next we are inserting the CT Lucia 602 lens. This patient's very well dilated. I typically like to place the leading haptic on the anterior surface of the iris, but since this patient's extremely dilated, I'm just going to let it kind of dangle in the posterior segment. But since that trailing haptic is in the main wound, it's not going to fall all the way back. Next, the 30 gauge TSK needle is taken and scleral tunneled. I then grab that leading haptic with microforceps and I feed it into the lumen of the TSK needle. You can see there's some vitreous hemorrhage occurring. We increased our IOP up to 60 at that point and it seemed to stop that. Next, I take a low temp cautery and put a bulb on the end of that haptic and just kind of bury it into the conj. Next, the nasal haptic is threaded into the TSK needle here using the microforceps, and that haptic is then externalized, and that is also melted with a low temp cautery to put a little bulb on it. Now here's the problem. We see when we insert that bulb that the IOL is kind of bisecting the center of the cornea and it's just sitting too far inferior, therefore it needs to be repositioned. That temporal haptic is too low, so therefore we go ahead and make a little peritomy. We expose that temporal haptic, and right now I am measuring to see how far superior we need to place the temporal haptic with a cyclodialysis spatula. I then just snip the bulb off of that temporal haptic with Westcott's, and I'm marking my new position for the scleral tunnel for that temporal haptic. I need to place it about 2.5 millimeters superior to the prior entry in order for it to kind of be more set, to help the IOL be more centered. So here we got it all positioned. Next I need to take the IOL and get that haptic out of its original scleral tunnel, just like that with some microforceps. When I did do that, the haptic then falls into the posterior segment along the nasal aspect of the eye. I then had to take my cutter under aspiration, grab the CT Lucia at the optic, and I use microforceps to then grab the haptic and place it into the anterior chamber, resting it on top of the anterior part of the iris to allow me to then get it into the TSK needle. So here we are making another scleral tunnel with our TSK needle, but this time 2.5 millimeters superior to the prior entry point. I'm then taking our microforceps, grabbing the haptic that I placed on the anterior surface of the iris, and then just threading that into the TSK needle. It is kind of an awkward angle since the haptic is meeting the TSK needle lumen at about 90 degrees. I find that if I place the haptic into the TSK needle with a little bit of pressure and pull the TSK needle out a little bit, that haptic then wants to go into the lumen. And look at that, our IOL is nice and centered. I then just closed the conjunctiva with some 6/0 plain gut. And our patient had a great result post-op day 1, 20/60.